The Senate Insurance and Labor Committee to order. We have 1 hour. We have 4 bills. We're going to try to limit it to 15 minutes per bill. I know we have sign-up sheets out there, but we're going to have to limit testimony so that we can get through our work. It's that time of session where we've got folks scattered in House committees, Senate committees, budget meetings, all kind of stuff going on. We're doing a hearing only. We do not have a quorum. We're doing a hearing only on these 4 bills. And we're going to start with House Bill 87, Representative David Clark. The bills are in your folder, and we need to verify Representative Clark, the LC number, because there was, I think, a House Committee sub, I think, maybe. So I have LC 520846S. Okay. Let me turn your mics on. All right. Start the clock. 15 minutes, please.
And then to
Yes, sir.
clarify why you had that substitute, we just removed the state health care benefits. We took that one, it was like 2 lines out. So this is just covering with insurance companies, which we have worked out. So today I asked for your support in House Bill 87, legislation that will make life better for Georgians with limb loss or limb differences. As you can see, okay. We were going to get you a picture in your folder. Not sure if it's in there, of Elliot, the 6-year-old. But I remember this past summer when Elliot, 6 years old, you might have seen him when so Everybody Can Move Day back at the beginning of session. He was down here. His mom, Susie, and the So Everybody Can Move team told me this past summer about the need for better insurance coverage for secondary prosthetics and orthotics coverage that isn't available in Georgia right now. Elliot and it really impacted me, as a 6-year-old who lost his leg as a baby. He just wants to run, play with his twin brother, Hudson, his older brother, Sebastian, just like any other kid. His parents hope that when he grows up, is no longer on their insurance, he will still have access to a running leg so he can stay active. This bill makes sure that people get the medical devices they need, not by adding new government programs, but by giving people the chance to live full, independent lives. Right now, many insurance plans deny these basic needs, but things like showering, going to the bathroom, playing, and exercising aren't extras. They're everyday needs. Even we worked with Jesse Wethington and the Georgia Health Association of Health Plans agree that this bill will be good for members, and we've worked out on all sides on this bill and worked last 2 months. I want to mention a few individuals who you might have met around the Capitol. They've been a huge part of this, and I've got to know them. One, Brad O'Malley, a small business owner from Tucker, Georgia. He needs special orthotics to keep working, but his insurance won't cover them. And this bill would fix that, making sure people get the equipment that they need to stay active and independent and a part of society. Mohamed Massaquoi, you might have met him. He was down here at the Capitol, a former NFL wide receiver, a UGA graduate, lost his hand in an ATV accident. And now he speaks out to help others overcome challenges, not just those with limb loss, but everyone. He also graduated from Harvard Business School, so he knows a thing or two about pushing through tough situations. And let's be honest, which is harder, dealing with insurance companies or graduating from Harvard? Now he's using that same determination to help change these unfair policies in Georgia. Another one, Jared Wallace, a 4-time Paralympian from Athens. Go Dogs. He has shown the world what people with limb loss can accomplish, but even he gets denied coverage for something as basic as a shower leg. House Bill 87 recognizes that movement is essential to health. When a doctor prescribes these devices, they aren't a luxury. They help prevent bigger health problems down the road, which saves money in the long run and for the state. This bill is about people, helping those who face unique challenges. It allows people to take care of themselves and live their lives. We all know how important family is, how kids need to be able to grow and play, and how simple things like bathing should never be a struggle. This bill makes sure that people with a limb loss or limb differences can take part in everyday life like everyone else. Think about this. If any of us could end up needing these devices, if that happened, would you want your loved ones to be denied coverage for something as basic as walking or showering? or will it continue to let insurance companies decide who gets to live comfortably and who doesn't? I know this personally. My father recently battled a serious infection. If he had waited much longer, the doctor said he might have lost his leg. And I would never wish that on anyone. But if it did happen, I want my family or myself and any of you to be able to shower, to move, to live, and just be normal. And so simply the bill is just allowing those who need an extra, say, prosthetic to be able to, based on the doctor recommendations and the medical necessity in the bill definition, to be able to just live a normal life. And so it's pretty much what the bill does, just expanding it to be able to help those like Elliot
Okay.
go play in the playground.
Thank you, Representative. So I see lines 16 through 25 is the carve out for state health benefit plan and Medicaid. So this would only cover folks on a private healthcare plan. Is that your understanding?
Correct.
All right, so the state employees wouldn't get the benefit of this under the current version, or the people on Medicaid would
Not currently. We're working out the physical note on that. And so
And
we stripped that out of.
Representative, have you had any figures given to you about what this would do to group health premiums or individual health insurance premiums? I haven't received that information. I just wondered if you had it or.
My
Yeah.
name is Rachel Oyer. I'm listed as one of the speakers. Is it okay if I talk?
Yes.
Okay.
Rachel
Oyer,
Oyer, how do you spell Oyer?
Auyer.
And who are you with, Rachel?
Yes, sir. I represent GSOP, which is the Georgia Society of Orthotists and Prosthetists. I am the team lead for So Everybody Can Move here in the state of Georgia that's helping with the initiative. And so currently the documentation we have with Mr. Wethington, we did not discuss the financial ramifications because there's a high utilization boundary line that medical necessity would be determined by the insurance companies, and they were comfortable with that dollar amount currently as
Would you point to
utilization.
that in the bill, please? I guess that's line 28, maybe? Or that's just a definition. Point to that in the bill. I was kind of looking for that. Because
So
I'd been told that, but I don't really see it. Says providers will cover it. I guess the medically necessary on line 54, is that right? Line 53, all health benefit policies renewed or issued after January 1, 2026 shall include coverage for orthotic devices and prosthetic devices that are medically necessary for, and then it lists the activities.
yes, sir. So the change in that is that currently those activities of daily living are not covered by insurance. So it would be an expansion of their coverage, including those specific activities. Currently, prosthetists and orthotists cannot list any activity that a patient would use the device for, or it would be denied as deemed not medically necessary. So our change in language would be able to allow prosthetists and orthotists to be able to work in conjunction with a referral of a physician first and foremost. That's currently under Georgia code right now. All prosthetists and orthotists work as a licensure administered by the governor's office here. There's a board that admit people in, and so that's how they currently practice. They're not allowed to practice without a referral from a physician.
But it is mandating coverage
It's
if it's required for these four things, lines 55 through 61, is that right?
correct if in fact it's medically necessary deemed by the insurance company, meaning that they've hit the benchmarks that is required by the insurance company to then have these activities be covered.
Okay. And could insurance companies cover this currently without this law?
No, sir, they cannot.
They cannot. They're
They cannot.
prohibited from covering these.
Determined by the current language, yes, they are prohibited because it is actually deemed not medically necessary to shower.
So they don't have the flexibility to cover these if they wanted to.
I would hope that they would choose to do that. However, as a private practice owner, they do not.
Okay. All right. Representative, we have some questions from the committee. Thank you, ma'am.
Yes, sir.
Appreciate it. Yes.
Thank you, Chair. You all probably know I'm an orthopedic surgeon, so I deal with orthotics and prosthetics a lot in my practice. There's a wide range of what couldn't be necessary, everything from a custom splint for a hand injury to a sort of a standard prosthesis to a myoelectric. So there's a big variation in what might be required. Is that contemplated at all in the bill, or is it just left up to medical necessity, case by case?
Thank you so much for that question. Yes, it's not left up to medical necessity, as I've worked out with Mr. Wethington, that we would be utilizing the VA's best practices when medically necessary. As addition, the myoelectrics, which you're speaking of, are not actually prescribed for very many candidates, as they have to be able to hit certain benchmarks. We've tried to include that in the original language. However, the insurance companies did ask us to remove that type of language. We did have very clear standards of medical practice. However, they would have preferred us to remove that, so that way we could work it out using the VA's current standards.
Who's number 3? I think, well, go ahead, Senator
To
Robertson.
your chagrin. Ma'am,
Yes, sir.
I'm a law enforcement officer, not an orthopedic surgeon. I don't want to confuse anybody with that. Even though I sound like one from time to time. Couple things you said. So y'all have been working with the insurance companies on this legislation and private sector insurance companies,
Well, the tricky part is that it has to be state regulated private insurance.
right?
And so that's the only that we could actually, I just wanted to clarify that.
And you have been in conversation with them based on this legislation?
Yes, sir. Originally, it was a no-go, the way that we had it originally written, because we were referring to medical necessity to the physician's recommendation versus the insurance company's recommendation. And currently, that is not how insurance companies operate. It's through the medical necessity of the peer review done inside those private entities.
Yeah, another issue I have with insurance companies where they think their experts are better than the experts that we go and see. And explain to me your comment about showering.
Yes, sir. If I could just anecdotally tell you the experience I've had here under the Gold Dome. So most of the patients that we have brought here are very interested in seeing how they could be represented by all of us, those that are trying to change legislation, as well as those like yourselves who are public servants. You all have asked me, how much is this going to cost? That is the first question.
Excuse me. You made
sorry.
a comment about showering
I-
is not seen as a
Medical necessity.
medical necessity. Yes, ma'am.
Yes,
I have a
sir.
great chairman on this committee, but he will get impatient with me if I
I'm
don't
sorry.
hurry. So are you saying that some insurance companies do not think showering, i.e. hygiene, is a necessary daily task?
I don't think they think that, sir. I think it's how the language is written, is that it's not mandatory for them to cover it. Therefore, they don't cover it.
Okay, so
Thank you, Chairman. Mr. Whip.
Thank you, Chairman.
Senator Steele.
To the point of showering, I wish that some people in our chamber did that more often than they do. But with regards to cost,
Yes, sir.
you and I have had this conversation. Obviously, a wide range of expense, but because right now those with limb loss have different needs.
Yes, sir.
Is there kind of an average cost for a foot, a leg, a hand, an arm? Just kind of a range. Is it
It's a very-
$1,000? Is it $10,000?
So it's a very wide range. If you're talking orthotics, which is going to be significantly less. However, as Dr. Kirkpatrick did mention, there are myoelectric orthotics, which can be extremely expensive. So currently, the first is covered. So those high ends are covered by insurance companies, certain insurance companies, not all. So that is not what we're looking for, is in addition to the current cost. The additional ones, such as a shower leg, would be around $2,000. Some night splints for patients Currently, with private insurance, children who need daytime and nighttime splints or stretching devices because they have contractures, they can choose one. You cannot have both. And so Elliot, who's sitting in the back over there, his family had to make the decision for him to have a running prosthesis and also an everyday use prosthesis. They made that decision. Now, it wasn't they have figured out a way to make it possible for their son. But as I could speak on behalf of Mrs. Barrett, that they are looking to his future. And what does this look like sustainability wise? Because as you all know, children grow and they typically need new shoes. It's very similar with prosthetics and orthotics.
Thank you.
All right, we've got a couple minutes. We have a couple people signed up. So Abigail from the Shepherd Center, thank you all.
Hello, good afternoon, Mr. Chairman, members of the committee. My name's Abigail Thompson Garcia, and I'm Director of Government Relations and Advocacy for the Shepherd Center. So we're a specialty hospital and we treat traumatic brain injuries and spinal cord injuries. We also have treat a small patient population that has experienced limb loss due to a traumatic injury. So we are here to ask for your favorable consideration and to issue our strong support for House Bill 87. This is an important policy change that would provide more coverage for patients who have limb loss for a secondary prosthetic or orthotic. And it's needed because it helps with allowing them to get back to whatever their new normal is. This allows them to participate in their community more, or whether it be a recreational activity or a particular hobby of theirs. It's really broadening their horizon. And so we don't think that should be limited because they aren't able to have access to the necessary devices. This bill does have parameters around fiscal responsibility and coverage limits and accountability. There is a reporting requirement, and it also would encourage data collection around this. I think the biggest takeaway is that this is a very small frequency benefit. It's a small patient population. So you heard that they do cover the first one. This obviously gives the insurers the right to deny a claim if they don't feel it's medically necessary. So in that sense, we do feel it has some accountability and stop guards to it to, again, make sure the insurers have their proper review. So we would just ask that you would consider, I know it's a hearing only, but possibly, a vote, and we hope that you would support this bill.
Okay, thank you, Abigail. Thank you for what you all do at the Shepherd Center. And I'm gonna have to ask you all to be really quick because we're over the 15 minutes already. Susie and Elliot Barrett, and I'll let Susie speak and we'll say hello to Elliot. Hey, Elliot. Man, you look handsome. Very dapper.
Thank you very much for your time. I realize that we're already over. I'll make it short and sweet. My name is Susie Barrett. This is Elliot. He's one of my 3 children. He's a twin. He was born congenitally. We had no idea that he had limb loss in utero. And when we delivered, it was a surprise. We have been max out of pocket ever since he could walk. We got his first leg then when he was learning to crawl, and he crawled with it. And we soon realized the power of insurance and what we would be having to face for a future of planning and financial planning for our family. Each leg that he gets, which is once every couple of years, he grows with it, we adjust it, we move on. He wants to keep up with his brothers. He wants to play all the different sports that any other 6-year-old does. When he wanted to play soccer, we needed to get a running blade. Running blade was billed to our insurance at $70,000. We set up with payment plans with CHOA. My husband and I are pilots. We have very good insurance right now, and I'm grateful. I'm blessed beyond every measure. But when Elliot's no longer covered by my insurance and he wants to continue to play anything, he's not going to have that affordability. And as many as you know, being able to be mobile and be in sports or be in any kind of ability, it's more mental than it is physical health. I want him to be able to do anything he wants to do alongside his brothers and be able to continue that for the future. So that's the unknown threat for the future is that we don't know what insurance is going to look like. And I'm advocating on behalf of those who cannot afford a secondary leg. Right now, they have to go for a grant and they have to compete for a new leg if through some kind of outside enterprise. I don't want him to have to compete to get the mobility he needs in the future.
Okay.
Thank you.
Thank you very much.
You wanna say anything?
Thank you, Elliot.
It's the chair.
Okay, thank you all very much. Next bill is going to be House Bill 124, Representative Mitchell Scoggins. Hey, Representative.
How you doing, sir?
Good. Pull that mic close to you if you would, please. Thank you,
Okay.
sir.
Thank you, Mr. Chairman, committee members. This is House Bill 124, LC 520603. And this bill would amend Title 33 and some in Title 44 so as to require coverage for healthcare services for PANS and PANDAS. I do have a physical note from the state, and it is minimal impact on the physical note. I hope you got a copy of it. I left these folders on everybody's desk last week, and hoping that you got a chance to look at the physical note. I have extra copies here if you need to see one. But to explain a little bit about, I know y'all talked to Senator Watson a couple of weeks ago. Go ahead, you have a question?
I failed to realize there was a fiscal note in that folder and I didn't provide it to the committee members. I apologize.
Do you want me to give you a copy and let you?
Let's don't spend your time on that. Let's
Okay.
just,
Okay, and I know Senator Watson come in and talked to y'all about this same bill. It was a companion bill last week.
let's pull it,
And,
Representative.
So I'm hoping that we'll be able to discuss this bill, get some good conversation going. PANS and PANDAS is pediatric autoimmune neuropsychiatric disorder associated with strep throat. PANS is pediatric autoimmune neuropsychiatric syndrome. PANS and PANDAS usually happen in children between the age of 3 and 13. As they get older, their immune system gets stronger. Usually they grow out of the illness. Adults typically don't get PANS or PANDAS. Studies have shown that 1 in every 200 kids can possibly get PANS or PANDAS. Most kids will have strep throat 2 or 3 times a year during a school year. When school starts back, they're going to get strep throat, bring things home, and that's where PANDAS originates. PANS is somewhat different than PANDAS. PANS can come from other bacteria or viruses such as COVID or the flu. Both of these usually happen when a child has a weak immune system. The biggest difference in PANS and PANDAS is, of course, the strep throat infection. What happens when a child gets strep throat or other bacterial infections? The immune system produces antibodies and sends that out to fight the bacteria that's in the child's system. What happens when the antibodies are fighting between each other, they can also attack healthy cells. And those healthy cells are usually coming from the brain. The antibodies that attack both strep throat and healthy cells from the brain are called cross-reactive antibodies. They usually attack the part of the brain that controls movement, thought, and feelings. To tell you a little bit, I know we get bills down here from constituents that are brought to us and with an idea, but this is a personal issue with me. It's kind of hard to talk about, but I got a granddaughter that's 8 years old, and she got PANS 2 years ago. And what happened is she started getting sick. Every 2 weeks, she would either have a stomach virus, she would have strep throat, she would have COVID. So every 2 weeks, she was getting sick, and we couldn't figure out what was wrong with her. So we finally started researching, and we found out about PANS and PANDAS. Dr. Jill Dickerson in Noonan, she is one of the foremost experts in Georgia, and we got her to see Dr. Dickerson, and she evaluated her that she had PANS. And so it's been 2 years now. She's a lot better. She's 75 to 80% better than she was when she first started getting sick. What really brought our attention to it, she developed a tic, and y'all know probably know what a tic is, but it was a uncontrollable muscle reaction, and she did her head to the side like that. She was doing it like 20 times every minute, and we couldn't figure out what was causing that. But it was those healthy cells from the brain and the antibodies were fighting against each other, and that's what makes PANS and PANDAS. 12 other states have introduced the same or similar legislation and have passed this. The state of Virginia passed it last week, and the governor already signed the bill. And there's 17 other states now that has legislation working in the process for this year. If you look at those folders, there's a couple of things I want to bring your attention to. I have 5 letters in those folders from doctors who are expert in the field of PANS and PANDAS. 3 of those doctors are from Georgia. We also have letters and statements of support from other people, such as the professor of medicine in Columbia University has a letter in here that states that he is aware, and the clinical study that they did, what described as PANS and treatments for PANS. There's letters from 7 different clinical evaluations that were done that I received information from the National PANS and PANDAS Association that support this legislation to trying to get insurance to help with the sickness of these children. The American Academy of Pediatrics supports and recognizes this as a sickness. The trick to this is getting early treatment to PANS and PANDAS and getting them to a doctor, getting them on antibiotics, because early treatment prevents long-term effects from the PANS and PANDAS. Some kids untreated could carry things with them the rest of their life if untreated in serious cases. But most of them outgrow it during that time of 3 years old to 13, 14 years old. I don't know if y'all have questions. I'll be glad to try to answer any questions that you may have. And as I mentioned earlier, I can get you any other information that you need. We had a doctor lined up, and I know we don't have much time to speak from Zoom. She couldn't get away from her practice, but I know we can't get to that today. But I
I
will
don't
be.
think it's working anyway.
Oh, okay.
Uh,
Okay.
Representative Scoggins, you've been incredibly patient and courteous and respectful. And I appreciate that.
Yes, sir.
On your granddaughter, what treatment has been proven to be effective? Is it the antibiotics, or has it been you said she's a lot better, thank the Lord.
Yes. And
What has been the treatment that you think has helped her improve?
I failed to mention this, but a lot of the kids have joint problems, back problems, knee problems. And we got her on ozone therapy, which is a therapy that they do through IV. That a lot of athletes use that to speed up the healing process. It puts a lot of oxygen into the blood and pumps it back in, and it recycles that blood. That is the biggest thing I think that we did to help her with her joint pain and back aches and then her tic. That got rid of her tic. Her tic is gone.
Wonderful.
Yeah, and so the thing is that there's lots of things out there, and this bill is asking for the national. It's for the national accordance, in accordance with the national recommendation of the treatment for PANS. It doesn't include IVIG. That was a big question that we were asking in the House, but it does, recommend whatever the National Society for Medicine for Pediatrics uses to treat these, and that's mostly antibiotics and steroids.
Representative, you mentioned the American Academy of Pediatrics recognizes PANS and PANDAS.
Yes, sir.
We've got a report in our file, and I'm not trying to ambush you. I don't know if you've seen this. It just came out this month, March 2025, and it's an in-depth clinical report on guidance for rendering care for this. And there is a lack of consensus among physicians as to how to best treat this.
I would agree with that.
And, but I will, the committee now has this in your folder. I'll ask the committee to please look at that at some time later, but, I'm glad that you mentioned the IGIV. We heard a lot of testimony when the Senate bill came in and everything was surrounding this IGIV.
Right.
That's what they seemed to, the advocates were pushing for and talking about. And this report says other treatments that are not recommended. And it says the randomized controlled trial of treatment with IGIV did not show efficacy for children in whom PANS was diagnosed because of the lack of evidence strength for autoimmunity and the potential for adverse effects, including immunocompromised, severe headaches, anaphylaxis, aseptic meningitis, thromboembolic phenomena, hemolysis, renal failure, among other serious reactions. Treatment with invasive immunotherapies is not usually recommended. And the testimony we heard on the Senate bill, that was the one that was the, silver bullet to fix this. And it's apparently incredibly expensive, but it's not recommended by the American Academy of Pediatrics.
Well, and this.
There is there was talk about CHOA and the Senate test on the Senate bill, and CHOA has stood up a very limited pilot program. I think they're accepting 2 patients a month to try to kind of study this situation.
From what I understand, CHOA is trying to come up with a treatment that they could use to treat these kids with PANS and PANDAS. But if you'll notice on line 6 of the bill says in accordance with the national recognized clinical practice guidelines. That would be what the insurance would be covering. Just it's whatever's in that particular, that's particularly recognized by the national clinical practice. And it's not IVIG is not in that.
Yes, sir.
And the IVIG is basically, it's a treatment where they produce purified antibodies and they, from human plasma, they get it from a human who has that purified antibodies and they put it into this child or person that needs to an IV and it goes in and puts in new antibodies into their bloodstream.
All right, I do have a question from Dr. Kirkpatrick.
Yeah, thank you for
Okay.
bringing the bill. I just, I'm trying to understand the treatment. It sounds like early diagnosis is really the
It's the
key
key.
because the primary treatment is early antibiotics to treat the infection, if I'm
Exactly.
understanding it correctly. And that the other treatments for later diagnosis are more in line with behavioral interventions and treatment of inflammatory symptoms like the joint symptoms you're
It is.
describing. And specifically not IVIG.
Not
in
IVIG, it's
this
not in this bill.
review article. So is that pretty much what your understanding is about the
Yes.
status of the treatment?
Yes, ma'am. Yes, ma'am. And I have Dr. Michelle Al here, who was a pediatrician. She serves in the house with us. And can she testify?
If she can do it in 2 minutes.
Okay. come on.
Hey, everyone. Nice to see you again.
Hey, Doc.
Representative Michelle Al, representing House District 50. I am a practicing physician in anesthesiology, but before that I did train in pediatrics, and I just wanted to support my friend Chair Scoggins here on this really important bill. Just to bring up that, in medicine, there are certain conditions that we call orphan diseases, and why we call them that is because it often affects a very small number of patients overall, and therefore they're often neglected, right? So due to that small patient population, there's often like limited financial incentives for research and development. Research is obviously constantly evolving our understanding of what the best treatment is. I believe this bill addresses what is currently accepted to be the current standard of care and bringing that up to speed for the state of Georgia, right? Insofar as we understand this disease now. So in so doing, not only can we treat this small cohort of patients that can be quite severely affected, but we can also show the patients in Georgia who are affected that they are not alone, that we are aware of this condition. I'm pretty confident that before Chair Scoggins came up that you probably hadn't heard of PANS and PANDAS unless you had this piece of paper put in front of you, right? So it kind of evolves awareness of disease and the importance of early treatment for streptococcal infection.
So do you have cases where insurance companies are not covering the antibiotics or the behavioral therapy?
Just from word to mouth, you know, that they
Okay.
don't cover. And I don't
Because I
know,
mean, if you had spinal meningitis or you had an infection, certainly that should be covered.
Right.
Treatment for that, and then we're supposed to have mental health parity. Um, and sometimes that needs to be the insurance companies need to be reminded of that. But I just was curious if y'all had specific actual examples
Just a
that
lot
we
of
could
ad-
run down.
just a lot of advocates that come up and talk to us about they were turned down by their insurance for pay. But this is really a good bill that I think we can help children with and help families with not a lot of cost to the state or other insurance.
And just to be clear, you're not pushing for coverage for IGIV.
Exactly. No, I'm not.
Okay. I appreciate it very much.
Okay.
Thank you.
Thank you.
Thank you.
All right, next up, my good friend Representative Karen Mathiak, House Bill 323. Deals with under 65 Medigap coverage. And who do you have with you? Well, I'll let her introduce herself.
Yes, thank you, Mr. Chairman. I so appreciate this time today. This is Elizabeth Lively, and she is with
Dialysis Patient
Dialysis.
Citizens.
Thank you. So today, you're right, what we're trying to do is look at the affordability of Medigap for patients under 65 with,
Go ahead.
thank you, sir, end-stage renal failure and ALS. Those two diseases is what we're looking at. And again, under 65. So what Medigap does, and everybody knows in here, is the 20% that Medicare would not cover. So what we're asking is 65 and under to be able to use Medicare, and then that affordable 20% Medigap would afford them to be able to have a kidney transplant. Statistics show that if our patients under 65 have a kidney transplant, they're back to work in approximately 3 years, saving our state from Medicaid. Georgia took the first step to equalizing treatment in 2010, and Senator Watson and Harbison sponsored that bill back in 2010, and that provided one plan and that lowered premiums for our patients. This is a parity or an offering of insurance, not a mandate. There's about 26 patients in the last year and a half that have taken advantage of this or have looked into this. Overall, the Medigap pool would be about 1.9% or $4 a month in the overall pool. And that was something that I had talked to one of our other lobbyists in the insurance world about what would that cost the overall Medicare person. And that's what our average was. This will add a little over 5,000 members under 65, and that would shift them away from Medicaid. So that's kind of our cost savings to our state. We looked for some claims data and we weren't able to get that, but hopefully that'll be coming. And the next time you hear us, we will have some claims data from our insurance friends. At the end of the day, this is helping our Georgians that are dying from these two syndromes. And what we're aiming to do is make their last a little time on earth a little better. And if we can get them back to work, that's even better. There's 17 states that have acted in similar legislation. And again, it's no state dollars. We do have, and I think the Piedmont letter is in your packet of support, and AARP is neutral in this. We do have a patient. I understand that we can't do the Zoom. We couldn't do the Zoom. Is that correct? They didn't get that
I don't
fixed
think
yet?
it's working, so.
Okay,
Representative, can I ask you some questions?
absolutely,
So,
absolutely.
so currently you can get, normally you get on Medicare at age 65.
Correct,
And then there's a market, a private market to buy Medicare supplements or Medigap coverage.
correct,
So you would have to be eligible for Medicare and then you can buy a supplement.
correct.
If you have these conditions, you can get on Medicare under the age of 65.
Correct.
And there is a market for Medigap coverage currently for under 65 people that have these conditions, ALS and end-stage renal disease or failure.
Right.
It's just a lot more expensive premium than if you were 65 and getting the standard Medicare supplement. Correct?
I'm being told that it would be about 1.9%.
Well,
Which-
I'm just talking about
Okay.
the current
The
landscape.
current, right, right.
It's-
Well, yes, sir. And
And
that,
so the argument is the premium for you under 65 Medigap should be the same as for age 65 and older Medigap.
yes, sir.
And so to me, that sounds like a mandate. But you
It's,
you might disagree. So it is going to raise the premium for everybody, but it's going to lower the premium for those under 65.
correct.
So I see so that's a policy decision, for the committee to weigh.
Right.
We've been told the premium increases for those seniors 65 and up is 8 to 15%, but you seem like have data that is much less than that.
Right, because it's so few patients. We're not talking about a vast pool of patients. A
Have I
little over 5,000.
mischaracterized anything
No,
about?
you are great. My biggest concern is for somebody under 65, in order to have a kidney transplant, they have to, at first we were told $20,000 in escrow. It can be up to $100,000 depending on what type of insurance the patient may or may not have. So therein lies the problem, is the expense.
Okay.
So with
One
the,
more question and then I'll
Yes, sir.
turn it over to the committee.
okay,
At what point does the under 65 that has ALS or the renal failure eligible for Medicaid? Do they have to spend down their assets to
Yes.
be eligible for Medicaid?
yes.
Okay, that's kind of what I thought. All right. Questions from the committee, and then we have several people signed up to speak.
Yes, sir.
Thank
I'm
you.
not
My,
trying to cut you off. I
No,
just
you're
gotta
fine.
keep it
I'm
going.
sorry.
glad to be here.
my
So-
question's about the data part.
Yes, sir.
Because we have
Yes,
this
ma'am.
thing that we passed called the All Payer Claims Database, and all those claims are supposed to be on there. Have you reached out to them to try to get?
I did. Yes, ma'am, I did. And they've not been able to produce them, the database or the data itself.
Okay, I'll follow up. Thank
All right.
Thank you.
The Dean of the Senate.
Thank you, Mr. Chairman. I want to know about the actual, well, not necessarily, but estimate, because we're talking about a pool of about 30,000 people, 20,000 people who would be in the category of renal failure and ALS. How many people roughly? And that's
It's actually less than that. It's over a little over 5,000.
5,000.
Yes, sir.
And number two, so, and I thought I heard the chairman ask a similar question. I'm trying to get a clarity on that. Can you get Medicaid when you have, unfortunately, get ALS or renal failures? If you've been working or something, does that kick in? And does that work at all in the formula?
That's when the patient would be spending down their assets to be able to afford the kidney.
But that's Medicaid, is it not Medicare?
That's Medicaid, yes.
Okay, but so,
They'd have to have very little assets to qualify for Medicaid.
but you can't qualify if you can't get Medicare unless you're 65.
65, correct.
I
It's-
get that,
It's,
okay.
you see the quagmire. You really saw
Right.
that.
And so the 3,000 people total renal failure and ALS together would be the cost in that formula for the approximate increase. And that's, you said about $2 per insurance carrier or something
Yes.
like that.
Yes.
Is that right?
Not the carrier, it would be a broadcast of increase for everybody on Medicare.
Oh, that meant that. Okay.
Yes.
All right. Thank you very much. Appreciate it.
Yes.
Oh, sorry. The people, we've got several signed up to speak, so
Okay, is Elizabeth first on there?
she is. How
All
about
right.
that? Go ahead.
Thank you, Chairman Walker, Vice Chair Harbin, and members of the committee. My name is Elizabeth Lively. I'm the Eastern Region Advocacy Director for Dialysis Patient Citizens, and we're a nonprofit group that advocates on behalf of kidney failure patients. The bill that is before you today was passed in Indiana last year. It was compromised with the insurance companies. And it will allow in Georgia about 3,800 end-stage renal disease patients to get coverage with Medicare supplement without paying the exorbitant prices. For example, if you're 65, your premium is $148. From that same carrier, if you're 64, it's $2,222. Nobody can afford that, right? So people are spending down and they're going on the state's Medicaid program. You have in your folder a actuarial report from Health Management Associates. They're an independent third-party actuarial firm. They took a look at two things. One, what is the cost to the overall pool by putting in 3,800 kidney failure patients into a pool of 375,000+ individuals? They took 2019 Medicare claims data, the most recent available, and calculated that to have same as age 65 premiums would raise the pool by $2 a month. Further, on the last page of that report, you will see that they estimated the savings for the state Medicaid program, that 1 in 4 of those 3,800 people would not spend down Medicaid, and over 5 years, that would save the state $6.3 million. Okay. As Representative Mathiak mentioned, in Kentucky, there was a much richer bill that was passed. It became effective in January of 2024. Looking at the DaVita patients only in Georgia, out of 1,900 who are eligible to buy Medicare supplement, when that bill passed, 26 did. There's not going to be a charge to the finish line by these patients, all 3,800 of them, to buy these plans. They're not. It's going to be minimal. This is about patient choice. This is about premium parity. And the Medicaid savings in particular for the state of Georgia, I think is on point. The Kaiser Family Foundation came out with a report yesterday. I just saw it this morning that estimated what the states are going to experience when the federal cuts come down. The House Republican budget bill included up to $880 billion that would be cut out of the Medicaid program. In Georgia, your match, your federal medical assistance percentage from the feds is at 65%. You're going to get a 35% reduction from the federal government for your state Medicaid program. This bill, it's small, but it's helpful. It has no state money involved. It's going to prevent people from spending down to go on Medicaid. And once they do that, they're not going back. Thank you very much. I'm happy to
So
take any
I have a
questions.
question for you, and we better move on after this, but your math, I just find it, so you say there's 3,813 under 65, but it's only going to raise the premium $2 a month for the 378,000 people. So it's about almost 800,000 a month in additional premium. Is that right?
I'm sorry, I've lost you.
So 378,000 times $2
I have
is,
4.
It's $2.
Okay.
that's almost $8,000. It's 700 and yeah, so it's going to raise the premiums annually by $9 million on the over 65. And
I think that, Mr. Chairman, I think that is a simple math calculation. Our actuarial firm looked at actual claims data. I'm comparing, a pool number is very different than the calculation. You can't compare simple math to looking at the actuarial data.
I'm just using the figures you provided and I'm trying to just wrap my head around it
Yeah.
is all. Okay, thank you.
We can continue that. Mr. Chairman, apparently the Zoom is working. Could we allow that patient to?
So I
speak?
have two people signed up for the well, the next person is Richard McDaniel with the American Kidney Fund. If he could come forward, and then the Zoom person is next after that.
Okay,
We gotta be quick.
yes, sir.
So we have two signed up for ALS. I'm gonna only let one speak. I'm assuming they're gonna say something similar.
I believe that the patient that's on Zoom is a ALS patient.
Okay. Yes, sir. Go ahead.
Afternoon, everyone. Chairman Walker, Vice Chairman Harvin, and distinguished members of the committee. My name is Richard McDaniel, and I'm here today representing the American Kidney Fund, speaking on behalf of nearly 29,000 Georgians living with kidney failure. Many of you may know me from my time in these very halls, working on campaigns and legislative issues. But 5 years ago, my life changed dramatically when my kidneys failed. The journey has been very devastating, both physically and financially. I've endured multiple extended hospital stays, some lasting weeks at a time. I've been in intensive care, on a ventilator, fighting for my life. My left arm alone has undergone 12 surgical procedures. Each one of these stays, each procedure, each fighting for survival has come with its own costs, not just in dollars, but in opportunities lost. This disease doesn't just affect the patient, it impacts entire families. My wife, who was my fiance when this started, has been put through the ringer watching me struggle. Seeing the pain in her eyes when I'm suffering cuts deeper than the needles that are placed in my arm 3 times a week. The physical and mental toll extends far beyond just me. Like many others with this disease, I've had to step back from my career and watch my life savings disappear. But beyond the career and financial impact, what weighs heavily on me is how this disease affects my personal dreams. I've always hoped to become a father one day, but right now I can't even consider that possibility. The physical demands of dialysis, the constant medical procedures, and the financial strain have put the dream on hold indefinitely. I'm a numbers guy, and the numbers tell part of the story. Medicare covers 80% of medical costs for kidney patients, leaving us with about $17,000 per year in out-of-pocket costs. In Georgia, kidney patients under 65 are charged up to 900% more than Medigap plans than those over 65. I personally pay $3,500 every 3 months for Medigap plan. Think about that cost for a minute. The average income of kidney patients receiving assistance is less than $28,000 per year. That's because 80% of dialysis patients become too sick to work full-time. Not always because of their condition, but often because they can't afford the coverage that will help them stay healthy enough to work. I personally pay $3,500 every 3 months for my USAA Medigap plan, which is covered by the American Kidney Fund's Health Insurance Premium Assistance Program. Without this assistance, I simply couldn't afford this vital coverage. This creates a painful cycle without affordable Medigap coverage. Many patients can't qualify for kidney transplants because they're considered underinsured. Without transplants, they're stuck on dialysis, which costs Medicare over $93,000 per year per patient. Right now, about 4,000 Georgians are waiting for kidney transplants, but only 1 in 6 will get one. The bottom line is clear. The current system traps patients in a cycle of dialysis, prevents them from receiving life-changing transplants, and ultimately costs taxpayers more money.
Okay, I'm gonna ask you a couple of questions. We gotta give some other people some time. Do you know, how much does the dialysis cost per month? Do you know how much your insurance is paying for that or?
I mean, so the last time that I looked, one session would cost about $12,000, and that's just one session. But I looked at that the first time when that
That's
was
for one
4
day?
years. That was for one day, and that was 4 years ago, and I didn't look ever since. So,
Do you know how many companies do dialysis in Georgia?
and Georgia, no, I just know of 3 main ones: DaVita, Fresenius, and the other one escapes me. I've been with Fresenius for 5 years.
Okay. Thank you very much.
Mhm.
Um,
I just want to say one thing before we leave. Georgia prides itself on the best place to do business. It's the #1 place to do business. I think right now, this is bad business on if we accept this for people like myself. My goal is right now in 2025, I'm on to get on the transplant list, to get a transplant and to get back working, right? And so individuals like me, once we're back working, we create that cycle of income. And I just think, I really encourage you guys to adopt this bill. I know, Senator, you've been, supportive of it. And, I
Yes,
just wish we could, get the support.
Thank you for your courage.
Thank you.
All right. We're gonna let Melissa speak briefly on Zoom if it works. And then Sarah, if you don't mind, we're gonna let her be the spokesperson for ALS.
Hi,
Go ahead, Melissa.
you can hear me? Can you hear me today? Hi. Good
You
afternoon,
seem to be
Chairman and Committee.
frozen. I don't know how to work this.
Good afternoon. Can you hear me?
We can't hear you, Melissa. I don't know if you can hear us.
I can hear you. Can you hear me? Good afternoon. Am I
We're
on?
having technical difficulty. Let's let Sarah speak briefly. I'm
you able to
sorry,
hear me?
Melissa. We cannot hear you.
Okay.
Hi, Melissa. Hi, Garrett. So, she did pre-record a video, and if I can find that. I
You
can-
just need to speak to it
Yeah.
real quick, and this is, we got to let the other bill come forward.
4-year-old and a 2-year-old. I was diagnosed with ALS in June of 2023 at 34 years old, just 7 months after having my second son. I am advocating today for you to pass the HB 323 bill so that I and other Georgians under 65 years old living with ALS can be awarded the same protections as those over 65 receive. The amount of expenses that come with this disease is exponential. Since being diagnosed with ALS, I've lost my ability to walk, have minimal function of my hands and arms, and I am reliant on the life-saving measures of a ventilator while sleeping. The progression of my disease predicts that I will continue to lose the physical function of my body, including a decline in my lung capacity, ability to eat and swallow, and the ability to speak clearly. As a mom of young children, I fear how my family will handle the financial burden of my disease, in addition to the financial cost of having a family. Today, a 65-year-old female can secure Medigap coverage through Anthem Blue Cross Blue Shield of Georgia for $288 per month. If I chose the same plan today at my age of 36, the cost for me would be $2,610 per month. That is a difference of over $2,300 per month. And it's money I just don't have to spare. And with the progressive disease like ALS, I don't have the years to wait either. The money I would save would allow for me to plan for the financial burdens and costs that I might need for caretaking and life-saving measures, such as a trach and vent. I want to be able to live many more years and see my sons grow up. I ask you to pass the HB 323 bill so that you can provide me that opportunity. Thank you very much.
All right, thank you very much. Next, I'm gonna call up Jesse Weatherington.
Thank you, Mr. Chairman and
Thank you.
committee. I appreciate it, the time.
Thank you. Hey, Jesse.
Hey, Mr. Chairman. Good afternoon. Thank you, Mr. Chairman, members of the committee. I'm Jesse Wethington, President of the Georgia Association of Health Plans. We are here to respectfully oppose House Bill 323 as written to you today, and I'll try to keep my comments as brief as possible. I know the committee has other business. And really, our opposition centers around the fact of the cost shifting that this bill would entail between those in the under 65 and the over 65 populations that are currently able to buy supplemental Medicare policies. Of our 9 carrier members, 4 sell a significant amount of Medicare supplemental policies in the state, but all of our members felt strongly about this bill. Of the 4 carriers that are really participating in this market, 3 were able to get me back estimates of what they thought the estimated impact of 323 passing would be on premiums for those in the over 65 pool. And those came back in the range of 5 to 15% for one carrier, 8% for another carrier, and 8% again for the other carrier. So we think those, again, are reasonable estimates about what the impact to the over 65 population may be. And as you've heard, this really is about the cross subsidization between those 2 different pools. So right now you have the large number of individuals who are on Medicare by virtue of their age as being over 65. Premiums are much less for those individuals because they have the whole gamut of different diseases and treatments that they would be party to or receiving in the course of a year. Whereas the individuals who are under 65 are only able to access Medicare and a Medicare supplemental policy by virtue of having ALS or end-stage renal disease, which are 2 of the most, fantastically expensive conditions that you can have, in the American healthcare system. And so that's the reason why you see that large disparity in premiums between the over 65 and the above 65 populations, because the acuity of the patient in the under 65 med sub policy is absolutely the most expensive patients that we see. The issue of transplants was brought up. There should be no issue with access to insurance affecting the ability of an individual to receive a transplant. That's a question that the transplant centers would need to address. Section 504 of the 1973 Rehabilitation Act and the American Disabilities Act prohibit discrimination against an individual who is disabled and needing a transplant for the reason, any reason that's not based off the medical condition of that patient would potentially be a violation of either of those 2 federal laws. So those individuals should also be protected. Their insurance status shouldn't be able to affect their ability to receive a transplant. I think what this bill is really about is the relative reimbursement between the current Medicare and Medicaid dually eligible individuals. Medigap policies reimburse at a much higher amount. 3 times is what we have heard from the different companies that are selling med sub policies here. For the providers that are providing dialysis services, which again is a duopoly of companies. They have not offered any significant discounts to that treatment, despite it being on the market for 60 years now at this point. And again, those run in the range of $80,000, $81,000 a year. You heard the figure of $10,000 per course of treatment. That is reasonable. So again, if they're, the goal of this bill is to shift costs between that, those individuals would benefit from jumping into a pool, but we do want you to be all too aware of the policy choice that is considered in this. Chairman, I thought you summarized that very well. And you would be asking everybody in that over 65 population to subsidize this group under 65, which is a small number, but they're absolutely the most expensive people in terms of per member per month costs that we see. So for that, we have several issues with how this bill is presented.
All right. Senator Lucas has a question.
Let me ask you a question. Who you say you represent?
The Georgia Association of Health Plans.
If we had a Medicaid expansion, what would be the cost then?
I think those individuals would not be able to take advantage of Medicaid expansion per se, because they presently would either be on spend down or their income would also be fairly low. So I don't know that Medicaid expansion would necessarily have impact on this population of folks one way or the other.
Are you telling me that if we had Medicaid expansion, which would cover folks, that it would not have a difference when you start talking about premium price and what you're talking about for those of 65 years or older, or those that are younger? I mean, there would be certain, I would assume you had to have certain things along with you to be on Medicaid expansion, or you don't have the income to buy insurance.
So I think of the 3,000 or so people that were discussed as potentially benefiting from this, probably some number of those individuals would probably be able to qualify for Medicaid under expansion scenario. I would be guessing if I ventured a number for you, but this wouldn't fundamentally address that per se. These people are already covered by Medicare, which is covering 80% of the cost of their treatment. And the ones who are able to access Medicaid now, either by virtue of their income or through a spend down program, Medicaid then covers the other 20% of the cost. I think it's fair to say that some individuals would benefit through Medicaid expansion. Whatever number of that 3,200 odd, I would just be wagering a guess if I want to do that.
So just to drill down on that, some of these individuals with these conditions are on Medicaid. They're dual eligible for Medicare and Medicaid currently.
Yes, sir.
And that's based on assets or income.
Right. They would need to spend down or already have an income low enough to qualify. And at that point, you know, the federal taxpayer is covering 96% of the cost of this treatment.
Okay, thank you.
Thank you.
All right, that wraps up the hearing on House Bill 323. We have one more. It should be relatively quick, I would think. It's more straightforward. And that is Representative Glaze, House Bill 373. LC 461095S. So I guess there was a substitute house on this one.
So I want to say good afternoon.
Is that the
Chair-
correct LC
Yeah,
number?
That is
Yes,
correct,
ma'am.
sir. Good afternoon, Chairman Walker and Vice Chair Harbin and my Senate colleagues. We've read the correct LC, and this bill is legislation that would require major medical insurance coverage to offer an annual prostate cancer screening for certain men at high risk. This bill currently before you represents a vital step in improving early detection as well as treatment for prostate cancer, ultimately saving lives. 11,000 plus men in Georgia will actually get prostate cancer this year. 11%, based on the American Cancer Society, says they will actually die from cancer, prostate cancer. This bill will diagnose early and provide treatment for prostate cancer. It still remains one of the most commonly diagnosed cancers amongst men. And early detection is a key to improving survival rates. House Bill 373 ensures that men of high risk for prostate cancer, particularly those who have family history, will have access to these screenings. And by requiring insurance coverage for this screenings, this legislation aligns with our broader public health goals of prevention, early intervention, and cost-effective health care. This bill has strong support from medical professionals, patient advocacy groups, and concerned citizens who recognize the importance of access to preventive health care.
All right, I don't know a ton about all this really, but I do know that I get a PSA test annually and have been for years getting that, and it's always been covered by my insurance. What is this what problem are we trying to solve, I guess,
The
is
problem we're trying to solve is to highlight men who are under 50, as the law is required, men of age 50 or above will get these tests and they would be covered. For men under 50 who have the high probability due to family history of getting prostate cancer, they do not have this coverage in their insurance. And so 70% of men in the state are covered by private insurance. They get an annual exam. They have a blood test. And so we're asking for those whose doctors know that there's a clear evidence of family history where that risk is increased at 60% for prostate cancer, that those men could actually get the PSA or the DRE test to identify early cancer.
questions from the committee before I ask some more dumb stuff myself?
Thank you, Mr. Chair. I actually have two questions. One is, I'm used to things that are preventive in nature already being covered. So this is a little bit of a foreign concept to me that it's not, but the age, it's changed for mammogram screening and colonoscopy and things like that. What do the national guidelines say about screening for prostate cancer,
Well,
urologists, for example?
Well, it still is at 50, but we're talking about that target group of men under 50 who's have the family history. And we have not tackled that. And it looks like we should have, but we have not tackled that and just made sure that coverage was there for those men who have the family history and who are under the age of 50. And that's what we're trying to target and to tackle that particular group.
Senator Harbison.
Thank you, Mr. Chairman. Representative Glaze, I'm struggling with the members of the committee too. Did we not pass this last session or a bill like this similar? I want to commend you for bringing it because it's a real problem, but I somehow thought we had passed this last session. And it was a House bill, if I recall correctly.
Well, based on Ledge Council, they actually did the background work and research, and it is not in the law. So maybe it came out of the House and just didn't get passed, but it's, that work was done, the research to see if it was already codified into law. And I'll tell you where it would be codified, and it's not there. It would amend Article 1 of Chapter 24, Title 33 of the Official Code of Georgia Annotated.
Thank you very much.
Yes, sir.
Mr. Chairman, I've been on state health benefit ever since I was 24 years old. And when I always went to the doctor, they do blood work. And basically you find out that you have a problem through your PSA. Are we saying that other insurance companies don't do it or don't allow for it?
That was sort of where I was trying to go with my line of questioning too, because I've never known mine not to cover it, but do you know?
It's not codified into law.
So what you're saying is our insurance covers it, but the other insurance companies
We're
don't
talking
cover
about
it.
private, just private. We're not talking about state or Medicaid or Medicare. We're only talking about private insurance.
Okay.
That is where it's not codified into law to require that. And we're grateful that we have so many members of this committee who are using the state plan and are moving forward and can get it. But this is just private. It's not state, and it's not Medicaid.
Senator Harvin.
Yes, question is, do you know the cost that is there a fiscal element or a cost that's here? Because it looks like the high risk issue is 49 or 40 to 49 with a family history, 50 and older. And then it says that or other men is may be determined by the physician. So the physician is also the determinant factor of determining whether someone is a high risk or not. Is that how I'm reading this correctly?
You're reading that correctly in reference to that. So the PSA test, it on average costs is about $33. Sometime it can range from 18 to 84. But 70% of men in the state still hold private insurance. And so they are not covered under 50. And so all this does is codify and allows for the state to require those private insurance to help our men 40 to 49, those younger ages who have that family history to get those screenings. There are usually already are going for annual tests. And what we're asking is that the PSA test would be offered to them as a part of their annual checkup. those who have the family history.
Senator Steele and then Senator Kirkpatrick.
Thank you, Chairman. If you could make a note, I think Senators Lucas and the Dean have better memories than all of us. The governor signed into law last year, House Bill 384. So you're correct, sir, on that. It states every insurer subject to paragraph 2 of subsection B of this code, so it's the same code section, shall provide notification to each male insured upon such male attaining the age of 40 and annually thereafter of coverage for an annual PSA test for the covered males who are 45 of age or older, or for covered males who are 40 years of age or older, if by ordered by physician. So it sounds like we're getting really close, but I mean, it was signed into law to be able to do that. The LC on that was 339366. But anyway, I just, since we're all pinging about the same, so it's not identical to yours, but it's got a lot of the same language, and I think, but it was signed by the governor.
Thank you. Senator Kirkpatrick.
Yeah, I'm looking at the same bill, House Bill 384, Representative Henderson. But the way I'm reading it, it's more of a notification.
Yeah, it was
bill
a no, yes.
that people, when they turn 45, get notified, but it doesn't really say anything about coverage.
Yeah. And it was
That's
a
how I'm reading it.
resolution. It wasn't, yeah, it's just notification. This actually goes to the next step.
Okay. Any other questions? All right. Thank you, Representative. Is there any other business to come before the committee? Oh, I'm sorry. We had Whitney Griggs wanted to speak to this. Whitney, come forward.
I can be super fast. I'm Whitney Griggs. I'm here professionally in my capacity as the Director of Health Policy for Georgians for a Healthy Future. We're a nonprofit focused on policy change to ensure that all Georgians have the ability to live the healthiest lives possible. Access to low cost efficient preventive screenings is essential to that. Also, to answer the question about our prostate exams required to be covered by insurance by law. They're not one of the preventive services that are required under the Affordable Care Act. So it is up to the insurer to decide whether or not they cover these services. But I'm also here in my personal capacity. My dad is one of the statistics that the representative mentioned. He passed away in September from a very aggressive form of prostate cancer. He went to his annual exam in 2021 with normal PSA levels. In 2022, he had to delay his appointment by just a few months. And the day before his youngest grandchild, my daughter, was born, his PSA was through the roof. When they did further tests, he had developed stage 4 prostate cancer that had metastasized to his bones. This, although it's very common and lots of men are able to get treatment and live long, healthy lives afterwards, it can also be a very aggressive, fast-growing cancer. And no family should have to say goodbye to a loved one before they have to, due to a lack of availability of a low-cost test like a PSA screening.
Thank you. All right. Any other business today? If not, I don't see any, so we'll stand adjourned. Thank you, committee.